everyone for joining me today. This is the second of our Dying Virtual Journal Club meetings, and I'm particularly excited to have a good discussion about Ray Dorsey's recent publication in Nature Reviews Neurology. Folks on the line, I'm sure you've all read the manuscript, and I'm really excited about the different threads that run through this piece. I think it's particularly relevant to our community at Dyme. I think looking at the intersection of different telemedicine approaches with supportive technologies, thinking about how the patients and the physicians sort of work with this, how we integrate these new tools into our existing sort of care delivery structures, both in high and low resource settings is really fascinating. And I certainly have a long laundry list of questions for Ray, and I'm sure that you guys do too. So for folks who don't know Ray, I am very proud to say he's on our scientific leadership board here at Dyme. He's also a professor of neurology and director of the Center for Health and Technology up at the University of Rochester Medical Clinic. Ray, over the years, both here at Dyme and previously at City, has taught me an awful lot about technology. So I'm always thrilled to have the opportunity to jump on the line with him. And our approach for today, we'll keep this quite informal. It's a small group. Ray is going to walk us through a couple of high points from his perspective as first author of this particular manuscript, and then we'll throw it open to discussion. What we'll do is, instead of doing formal introductions, when you ask your first question, if you can just let us know sort of who you are and your particular interest in this field, it will give us a more informal approach to a great discussion. So Ray, thanks again for joining us. Thanks everyone for being on the line, and I'll hand over to you to dive in.
Thanks very much, Jen. Kudos to Jen and Andy Korobos for creating Dyme. They've probably done more in 2 or 3 months than most medical societies or societies do in 2 or 3 years, and delighted to be part of this informal discussion. So I'm just going to give you a few overview slides on the article, which some of you may have looked at, and then open it up to questions. I wanted to keep this as informal as possible. So the money slide is, this is the money slide. So if there were one thing I want you to take away, is that we envision that healthcare will move away from institutions, hospitals and clinics, towards home and mobile devices. Care, especially in I know the US the best, I think even outside the US, care will move away from expensive, depersonalized institutions, hospitals and clinics, to home and mobile devices. And this is exactly the same thing that we've seen happen to a wide range of other sectors in the economy. So the analogy we have at the bottom is to banking. So banking used to be done with a bank at a bank teller, and then you did an ATM, and that ATM was located in the bank, and then the ATM was located in the shopping mall, and then located in a wide range of locations. And then almost everyone listening here probably does banking at home or banking on a mobile device. And you could think about the same thing applying to travel services. You could think the same thing about education. You could think the same thing happening to shopping. And we've even seen in telehealth that there's been a migration in just telehealth, not just healthcare, of moving from investigations that look to provide remote expertise into hospitals, especially stroke, to now more and more interest in looking at care being provided into home and onto mobile devices. So that's the dominant theme that will run through the rest of the discussion. So this is not surprisingly, number of teleneurology studies has increased dramatically over the last 20 years. The idea for teleneurology began in 1999, really, with an article about telestroke, and they showed an old VHS camera and a television screen, and the idea you could care for a patient who had a stroke in a rural hospital by providing a connection to a stroke neurologist who might be located in an urban center. And so you can see in black there's been a rise in telestroke applications, but more prominently a rise in green of applications beyond just stroke. And here's a list of studies that have been done where the sample size is greater than 100, looking at applications of teleneurology for an increasingly wide range of conditions, including headache, cerebral palsy, spinal cord injury, multiple sclerosis, wide range of geographic locations, wide range of clinicians, and in more recent years, a focus on delivering care to the patient in the home as opposed to in a clinical setting. In addition to using technology to deliver care, technology is increasingly being used to measure outcomes. So in neurology, we have very subjective ways of assessing people's condition. If you think about pain, we have happy faces and smiley faces to measure pain. For depression, we have rating scales. For Parkinson's disease, we have rating scales. We really have no objective way of measuring the disease, and the inability to get objective measurement of the disease leads to inability to develop highly effective treatments for the disease. Think about Alzheimer's disease, and leads to inability to deliver personalized care based on how people are functioning in their natural environment. And so there's been an exponential rise in the number of studies looking at smartphones and wearable sensors in neurology, and I strongly suspect that this is not unique to neurology. And again, there have been increasing number of studies that have looked at smartphones for Parkinson's disease predominantly. And again, you can see these are occurring in the clinic, at home, at work, or sometimes anywhere. Similarly, wearable sensor studies, again, to assess diseases that have external manifestations like multiple sclerosis, or Parkinson's disease, or Huntington's disease. Again, these studies are being conducted in a wide range of geographic locations, although predominantly most applications have been looking at in-clinic assessments, but we suspect that will change over time. Again, this is, to me, the most important slide is driving care out of institutions. And so if you look just in general, hospital admissions in the United States has been largely flat. And if you adjust the number of hospital admissions per person, it's actually been slowly declining. Whereas clinic visits have been going up, home visits are increasing, and teleneurology or telemedicine visits have been increasing exponentially, albeit on a small base. I think this is the last substantive slide, is that initially people think about telemedicine, not this audience, but initially about as a predominant means of providing care to people who live in rural settings. And these are data from the Ontario Telemedicine Network in Canada, which is one of the most robust telemedicine networks around. And in 2009, indeed, 2/3 of the visits that they were doing in the Ontario Telemedicine Network were to individuals in rural locations. But if you look at the trend from 2009 to 2014, there's been a clear rise in increasing adoption to people in urban settings. And if anything now, urban applications are more common than rural applications. And I think, again, you're going to see the same thing play out. You could argue the same thing happens in shopping. You know, if you're in rural Alabama, you know your shopping choices are more limited, and so Amazon offers you great value. But the people who are probably using Amazon the most are probably in Manhattan, New York. So I would think that once you leave that teleneurology or telemedicine is not necessarily a focus solely on rural areas, although it's great to bring care to people who don't otherwise have access, but the greatest adoption will likely be in urban centers for people like you and me who are looking for more convenient ways of receiving care. I'll stop and open up to any questions that you have.
Hey, Ray, it's Rob Wilson here. Quick question, like I know you've been involved in this area for quite a while, and I think of it as a, a two-sided equation, at least, with the patients on one side and the physicians on the other. In terms of embracing this technology, and are you seeing it? I mean, it looks like we're in the right direction, but do you feel that there's equal comfort now with physicians as well as patients? Physicians typically, they can resist technology change quite a bit until it is proven that that technology works to their benefit, both in terms of allocation of time as well as affecting positive outcomes with the patients. What are you seeing in terms of acceptance with both physician providers using these tools as well as patients?
So I think it's really, 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 really hard to get docs to change their behavior. And so I spend little time doing that. And if I were a company, I would not rest my company's future on trying to change physician behavior. I would be much more focused on patients, and I think patients are increasingly realizing that this seems to make sense, that they're not, I think people are just much more comfortable. They do these things at work, and they say the same communications that I'm using at work, and I use that to see my doctor, and it makes more and more sense to them. That said, at the University of Rochester just today, we have a neurologist who's putting together a telemedicine curriculum for neurology residents. So I think there is slow change coming. I think it's more likely to occur with younger physicians or more newly trained physicians who are coming in, some of whom are digital natives, and this makes lots of sense. People do like the convenience. Clearly for patients, it's more convenient. We've shown a number of studies that a telemedicine visit saves patients and their caregivers 3 hours of time and 100 miles of travel per visit. But it's really convenient for docs too. I had a colleague who was a neurologist, Parkinson's specialist, had 3 young kids, and couldn't work at UCSF, UC San Francisco, because the clinic shifts were 8 to 12 or 1 to 5, and what she really needed was a shift that was 10 to 2. But telemedicine allows people to make their own schedule and gives them a lot more freedom in terms of both the timing of visits and the location of the visits. So I think you're going to see more and more adoption, especially among digital natives, but it's going to be much more strongly driven by patients, and then 2 payers who might be viewing this as a lower cost way of delivering care than rather than risk bringing somebody into an institution and getting a very large emergency room visit bill.
Very helpful. Thanks.
Ray, I have a couple of questions that riff off Rob's, if I can. The first is around not sort of physician willingness to change, but I'm always really conscious of the conversation around physician burden right now. And I think, you mentioned the idea of, a move towards telemedicine can certainly help reduce that burden. But one of the other interesting things in the manuscript was this idea of sort of asynchronous communication, starting to add things like contact by email, being able to sort of synthesize all of the information from a variety of sensors, which gives you the opportunity to learn a lot about a patient between visits, but you need to carve out time to really sort of analyze that. So I have a question around sort of your thoughts around how we protect, especially neurologists, because really in the manuscript, you are a rare breed. How do we protect sort of your time and your burden and your stress levels? And how do we think about reimbursing for that really important time spent in non-face-to-face interaction with patient information?
Not well, I guess you're recording this. I think doctors are largely irrelevant in this, and I think largely irrelevant. The real power is using that information for patients to gain greater control over their own health. So the Wall Street Journal had an article last week about glucose sensing insulin pumps. And previously, you got your insulin dose based on getting your glucose checked when you were at the doctor's office, and the doctor would then prescribe you the insulin based on what your blood glucose levels in the doctor's office. And then you stuck yourself and you dosed your insulin based on your own readings. And now you don't prick yourself. The machine doses insulin based on information that it's sensing itself. And so I think that's the direction it'll go to. Docs are not like looking for more information to digest. And they certainly don't want to look at information between visits because they really don't get reimbursed for that, in at least in most of the fee-for-service world. I think it would have to be an entirely different system whereby docs would be like, Kaiser, and Kaiser carves out time for, I think they call it desktop medicine, to review data and do emails and asynchronous communications. I think the real power of these things is allowing patients to gain greater control of their health independent of clinicians. It was remarkable in that Wall Street Journal article. They had the picture of the device, picture of the patient. The only thing that there wasn't a picture of was the clinician.
That was not the answer I was expecting, but it's terrific, very interesting, and I'll need to dig out that article.
Hi Ray, this is Shamal Patel from Pfizer. I work in the digital medicine group here, and we focus on developing and deploying sort of new digital endpoints in our clinical trials. And the question I have for you is, we work on a lot of our efforts are directed towards validating new digital assessments and endpoints. Most of those are performed in some sort of controlled clinical setting. And then we always expect to translate these to at-home sort of free living environments, right? And so there are two challenges. One is that our digital assessments are typically tied to clinical assessments. So we might look at a 6-minute walk test or a UPDRS score to ground our digital assessments. And so, you know, their measurements are essentially validated and assessed with respect to these established clinical standards, which might themselves have some issues. And then when we go to the home setting, what we might be measuring might be completely different, as has been sort of, you know, highlighted in recent publications where people have shown that when you measure gait at home versus in the clinic, you're measuring two different things. In the clinic, the measurements you perform are closer to your maximum capacity, so closer to 95th percentile gait, versus at home, you are much closer to what you might get if you ask somebody to walk in a dual task mode, right? So we face this conundrum of, okay, you know, measurements that have been validated in the clinic are not really, you know, valid when you think about what we are measuring at home. But then at home, how do you validate it, you know, because then you have sort of the chicken and egg problem, because there's nothing digital that has already been validated that you can compare against, right? So I was, you know, curious to hear if you have any thoughts on this.
Yeah, so Shamal, many thanks for the question. Full disclosure, I do work with Pfizer on this exact issue with, maybe you probably know Joe Mather. So I think we miss a ton. One of my other slides is a street lamp at night. And so what we currently see for patients is what's under the street lamp when they're in the clinic in an artificial environment at an arbitrary time. And that's when we initially measured blood glucose levels, you know, maybe after they were a fast and not after they ate ice cream at home. And that's when we do timed walking tests, and that's when we administer rating scales. But the 99.99% of the time that they're not in the clinic or in a research study, we have no idea what's going on. We're completely in the dark. And so I think the way to do this is exactly as you suggest: do observational studies with the new digital measure, say a wearable sensor, do traditional rating scales alongside them in the clinic, and that will give you some sense that the wearable sensor is correlating with a traditional measure. And the home, you don't have a ground truth. Sometimes we have actually gone out to people's homes and done the rating scale in the home while we're sensing them. But the real value is getting what's going on in their real world setting. And there you can get not just, you know, assessments every month or every 3 months, but you can get continuous assessments. There's a great book by Sandy Petlin, Alex Petlin at MIT, called Social Physics. And he says we should be measuring health outcomes, a number of assessments per second. And right now what we do is we get a number of assessments per month or per 3 months. I think the real value is for these tools to give us information on how they're doing in real world settings. The FDA is looking for that information. If you were to take an example like back pain, and you show that your intervention led to people walking more versus the control group had no change in their walking, I think that's much more valuable than to say whether they were walked a little bit faster in clinic on a given day after they were sitting in a car for 3 hours to come into clinic. So I just think that the value of the information in the real world is, one, more important, more relevant, and far richer in terms of just volume and meaningfulness than what we get in the clinic. And we know that for a wide range of diseases, anything from diabetes to Parkinson's disease, that people's symptoms fluctuate substantially, even within an hour that they can fluctuate. Think about pain. And right now we get very artificial snapshots, which lead us to a very incomplete picture. And oh, by the way, from a pharma perspective, all of that leads to shortcomings in your outcome measure and biases you toward the null to finding that your drug that might be effective is actually not effective.
Hi, I'm Ann Kim, and I was actually a student of Sandy Pentland at the MIT Media Lab.
There you go.
And so, I actually did clinical trial data sharing in like a privacy-preserving way using something called federated learning. And so I like the discussion that we've been having here, but I feel like no one has discussed how telemedicine and the clinical endpoints from mobile devices have to do with privacy and security of individuals. Can somebody tell me about the challenges that they face taking like measures that they found, in clinical settings versus actually deploying it? Because I think that's something that is part of the discussion when you're talking about measures like social physics, actually.
So we've done it with one of your colleagues, also at MIT, Dina Katabi, is a professor who's developed this Emerald device,
yeah,
wave sensor. And so we deployed it into the homes of people with Parkinson's disease. And it allows you to passively monitor people's sleep, their gait, where they are in the room, how many people are in the room. It's basically like a spy. And so we asked them about privacy. We asked the participants about privacy concerns, and they generally were not in the first 7-person study. And then we've expanded it to like 40, and then we have another study going on. I would say the biggest thing and we've done this for wearable sensors and the like, the biggest thing is that I think people with a disease have a much more different concept of privacy and willingness to share information than people without a disease. People with a disease want a treatment, and they want better measures, better treatments, and they want it now. And if they don't want it now for themselves, they want it in time for their children who might be at risk of developing the same diseases. So I think people with a disease or at risk for a disease are much more willing to sacrifice privacy concerns than people without the disease and healthy individuals. There was a great article, and again, I read the Wall Street Journal, on 23andMe, and a person carries a genetic mutation for Parkinson's disease, and she described how much she was willing to compromise her privacy in order to accelerate the development of a new treatment for it. That said, I think most research participants trust their researchers to not use their data in a way that's going to compromise their individual privacy. I think people get more concerned about how that data may be used by third parties. It's pretty easy to track me down, and so if you're a research participant in one of my studies and you think that your data have been used in an inappropriate way, I will hear about it. And I belong to a social network that would ostracize me if I did things that were particularly egregious. And so within a closed community like of researchers, I think there are lots of things that drive people to the right behavior. I think when you get to third parties that are outside of that, then there are greater risks involved. It's like, there's a great line that laws are used to govern the interactions among strangers. If you have a closed society, people in your dorm room, or in your dorm, you don't draft a list of laws to govern your interactions because you guys can self-police yourselves. It's really only when you get interactions with other schools, for example, that people become more concerned about how other people are going to treat them.
Can I ask a follow-up question?
Yeah.
So you addressed the privacy concerns of people with disease, and I understand those. Like talking to people who are terminally ill, they're very open to sharing all of their data actually on the internet just to find a cure. But I think there's some unaddressed part of society of like people pre-diagnosis that they think they're healthy, and so they might have more concerns about their privacy because, I think an example would be like, I'm sort of concerned about my Facebook data being used, but in some future, maybe like 5 years down the line, Facebook has longitudinal evidence to say that I have like, Parkinson's or something, then at that point I would care. but during that longitudinal like data collection, I would not want them to have that data, you know?
So there's a law called GINA, the Genetic Information Non-Discrimination Act, that bars discrimination based on genetic information. Think about your prodromal comments in employment and in health insurance, but not
life insurance.
But not life insurance and not long-term care insurance. And is like very well versed in this. The architect of that bill was Congressman Louis Slaughter from Rochester, New York. So there are some protections, but they aren't very good, and they are. I wouldn't say very good. It's they're incomplete.
And proving discrimination is very difficult in court of law. Even just for like gender, I think it's still very difficult. So genetically, I think it would be, you know, an even steeper battle.
So I would be concerned if my employer, for example, had health information on me. I would be concerned, or even on your family.
Right.
So you can imagine that if you're especially a small employer, that you're not looking to employ people who are going to have high healthcare expenditures, and if you're insuring, if you're not self-insured, you know, your insurance premiums are likely to go up. So yes, I think there are real concerns around that front.
Okay.
Largely unaddressed, at least to my knowledge.
All right. I would love to follow up on like an offline conversation. I don't want to monopolize it, but thank you.
Thank you. Thanks, Anna.
Okay, since nobody's asking another question, I'll go. So, Shamal again. I have a question about a specific sentence in the paper. So, you mentioned that, you know, the rise of teleneurology will enable greater variety of clinicians to play a part in patient care. I would imagine that the tools that in that scenario that these providers will need would be very different from what they're used to today. Do you have any thoughts on what that might be and how you would achieve this type of coordinated care where you have, you know, different data streams that are being used by different people? Would that be, you know, sort of fairly chaotic, or how would that play out, like, you know, in a sort of a scenario?
Tell me what the first part, what the sentence say?
It says the rise of teleneurology will also enable greater variety of clinicians to play a part in patient care. In addition to traditional clinicians, for example, neurologists, psychologists, nurses, right? So the idea that there will be different, you know, people who are going to look at your information and act in a coordinated way to take care of you.
Oh yeah, I mean, I don't know. I think there'll be more clinicians, that will have more interactions with a wider range of clinicians, and clinicians will be defined broadly. But two, I'm not sure how well it'll be coordinated in the near term. So I think there'll be more fragmentation of care and not less. And so I think, you know, right now, say you have Lou Gehrig's disease, ALS, and you want to go to the clinic and you want to see not only the neurologist, but you want to see a social worker because you have questions about disability insurance. You want to see the physical therapist because you want to stay mobile. You want to see the occupational therapist because you need a walking device. And you want to see the dietitian because you're having some trouble swallowing and know what modifications to your diet are necessary. That promise of multidisciplinary care all under the same roof is extremely difficult to execute, and very, 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 very few centers have been able to do it in an effective way, because you need to co-locate people in space, and you need to kind of co-locate, get people at the same time. So bringing people at the same time and same place is very, very difficult to do. We're doing a synchronous, discussion, but we're not co-located in space. I think telemedicine will allow people to have those interactions independent of one another, so that they'll see their neurologist and they go home, and maybe the dietitian calls and does a video visit the next day, and the physical therapist does a home visit, and the occupational therapist does a telephone, or the social worker does a telephone call, and that people will be able to be connected in wide range of means to a wide group of specialists. There are even companies, for example, that are like lactation consultants, because right now nursing mothers get, maybe a lactation consultant, 3 hours after they gave birth, all of a sudden the lactation consultant comes in and sees how breastfeeding is, and then it's like never done again. And the last thing I've never been a new mother, but I would presume the last thing a new mother wants to do is to take their infant and drive to go see a lactation consultant to talk about breastfeeding. They'd much rather either have the lactation consultant with them in the room, virtually, or in person. And so I think there are ways to bring in a wide range of clinicians or even non-clinicians to provide care to people over time. And it might be a one-time consultation. It could be an ongoing relationship, but that this will lead to more fragmentation of care and will not necessarily be coordinated, especially at the outset.
Thanks.
Oh, Ray, can you see the comments? There's a quick question from someone in a comment box.
Oh, let me see.
Here, I'll read it. It's from Atiscan. We still need utility studies of wearables evaluating long-term outcomes, but the technology is constantly changing. This may present a challenge in terms of support for those technologies in the long run. It's a great comment. How did you guys consider that in the review that you worked on?
So I'm not a technology. I mean, I'm not a technology guy, so I don't know technology. I'm a neurologist. I tend to think this is overplayed, but again, I'm a neurologist. Like, we have imaging, we have MRI and CAT scans, and those are always being upgraded, and the software is being changed all the time. But we don't get bent out of shape about, at least I don't get bent out of shape about longitudinal studies looking at MRI changes or CAT scan changes, imaging changes for a wide range of diseases. There are people, Rob and others know this stuff better than I do. I think these are incremental improvements, and they'll probably have some small changes into it. But I think you're looking for these wearable sensors to detect big changes. You're not looking to see if your gait speed went from 1 meter per second to 1.001 meters per second. That, if you're trying to determine that, then these changes might matter. You're trying to determine, do people's gait speed decrease by 20%, by 30% when they're at home versus in the clinic? Does it change by 10 or 20% over time as the disease progresses? So I don't think these software changes are going to be large impact on it. I think it tends to be overly concerned, but again, I'm not an expert in that area.
Well, I would just, Ray, this is Rob. I would agree with that comment. I think the issue is that technology always changes, and that in this instance, if you just look at wearable sensors, you had originally Actigraph, which was obviously a clinical grade tool, and Philips had a clinical grade tool. But the functionality that's now presented, and I know most of these consumer-centric devices quite well, Garmin and Fitbit and Apple and others, they bring some functionality that is enhancing what used to be collected at the clinical grade. So I think it's much more important, and Jen knows this, if you focus on what the digital clinical endpoint of meaning is as it relates to that patient and work back to whether the sensor supports the analysis of that clinical change, I think that's almost more important than just insisting on, just one type of sensor, because we're on a learning curve here, and as we gain knowledge, and by the way, there are major cohort studies that are being developed now with large wearable sensor databases. The biggest one is probably, the German cohort study, which is 200,000 people in, 19 different academic settings, and all of them are wearing 24/7 wearable sensors. As that information gets collected, digested, analyzed, then that will show a path forward to what value you might derive from that as it relates to activity and sleep measures. But I agree with Ray completely on this, is we've got to move forward, and so we need to build a body of evidence that's scientifically validated, but keep our eyes open that these sensors and technologies are going to constantly evolve. And so before, where it was impossible to get accurate, ECG or heart rate measures or pulse ox measures, with these sensors, that gap is closing. So we don't want to say we're not going to consider it. So if we begin with endpoint and we work back to to some trust and the sensor delivers on that particular measure, then we can build a body of evidence for improving patient care, irrespective of the generation of the sensor that's delivering that data.
I agree with Rob.
Hey, I have another question about some digital endpoints. So from your perspective, Ray, you've done a lot of work, and others might also have some input here. In neurology and sort of teleneurology and assessing aspects of the neurological symptoms at home, what are some of the most promising areas that you see where you can see translation of these assessments as either endpoints in clinical trials or potentially in clinical practice?
So I think the most promising areas are for conditions where our current measures stink, and for which the digital measures work well. So I'll give examples. So we have really good measures of HIV. You can measure how much virus is in the blood. You can measure people's CD4 counts. And so you can tell in a very short period of time whether a drug is likely to be effective or not effective. And therefore the need for digital measures is relatively low. Colon cancer, we have really terrible measures of colon cancer, right? You have to do a colonoscopy. I'm coming up on 50, and so I'm gonna have to get a colonoscopy soon. I'm not looking forward to it. And that's the only way to tell whether I have likely to have pre-colon cancer is to do a colonoscopy. And I don't know if there's a digital measure that can help determine whether someone has colon cancer. I would think it'd be hard to do. Conversely, pain, I think we have terrible measures. We have happy faces and smiley faces, which I don't think 50 years from now, people are going to go, wow, did they have that down cold? They ask people how much pain they were in based on a smiley face at an artificial time and artificial environment. So, but I think, here you can measure, activity, and again, for low back pain, it would seem to be a very strong evidence that if your drug or device or surgery made people more active as measured by an accelerometer versus people who didn't get that intervention, they were less active, that's not a very meaningful endpoint. So I think some areas, and I think they tend to be in neuropsychiatric conditions, again, I'm a neurologist, so I'm biased, but from my perspective, we have terrible measures of Alzheimer's disease. Anyone who's looked at the Alzheimer's disease rating scale, the ADAS-Cog is like, A, it's almost unintelligible, and B, it's completely subjective. And similarly for Parkinson's disease and Huntington's disease and other ALS, we have functional rating scales. So I think areas where we have terrible measures of the disease and areas where digital measures could give us insights and can quantify various aspects of the disease, I think those would be valuable. And the last thing I'll say is the creativity comes around how can you use that digital measure to assess the disease. And so for Parkinson's disease, this really opened up, at least for smartphone, with Max Little, a mathematician in the United Kingdom, who showed that mathematical analysis of voice recordings could differentiate people with Parkinson's disease from those without. So he took that piece of data and said, well, we can assess that with a smartphone microphone and use that to start to assess Parkinson's disease. No one a priori would have said we should start with voice as a key way of assessing disease, but I think if you come up with clever ways of assessing diseases in new ways, you'll get new insights and potentially more effective measures of the disease.
Ray, just riffing off your answer to that question and then some comments a little bit earlier about some of the more commercial technologies as well and how we can think about those. In your comments now and then also in the manuscript where you have some terrific tables about various smartphone studies and sort of sensor studies, how well are we doing as a field in transferring knowledge from those studies that are, I think, increasingly common to things like trial designs where we can select endpoints, to care delivery, you also mentioned, citizen scientists, people do it, who are part of that quantified self movement. How are we taking all of this knowledge that we're accumulating and transferring it to these different groups?
I think the group that's going to change this is pharma or people involved in drug or device development. There's a clear economic value for getting better measures of the disease, because if you have better measures, you can tell in a shorter period of time whether your drug works or doesn't work. and you can do it in a smaller number of individuals. So I think it'll actually be pharma, and I'll say pharma, but drug devices, biotech and the like, that drives adoption or use in the US. I think consumers will do it on their own, but that's unlikely to fundamentally change clinical practice and not likely to fundamentally change drug development in the short term. Like the people who are investing in this, like all these technologies are, Shala's on here from Pfizer, no one from Kaiser's on the phone, no one from the VA is on the phone, because in the US, you just generally don't get paid more to take better care of people. Versus pharma, if you have a device that lets you do a study faster, gives you information to make a go, no-go decision, smaller number of people, huge economic value. So I think that's where you'll see adoption and translation occur, is through them. And then once drugs are approved based on these new digital measures, then you can imagine that they'll be used post-marketing by either insurance companies wanting you to collect this data to see if they need to pay for the drug, or pharma wanting to see if the drug's effective in a broader population.
Fantastic. Ray, I want to make sure that I let everyone go on time. We were scheduled till 11:45 today. This was absolutely terrific. Congratulations again on a fantastic paper. I'll post that to our Slack space along with a recording of our discussion today. Certainly if folks had questions that we didn't get to today, we can continue that discussion on the Slack channel. And Ray, if you could just do me one favor and jump ahead to the next slide. Yes. Just a quick plug for our, thank you, for our next journal club. We have, see if I can get this from memory. I think Alan Godfrey, Jesse Backer, and Bill Wood will be discussing their systematic review of feasibility studies. So sort of winding it back and going a little bit further upstream from our discussion today. But Ray, this again was terrific. Thanks for taking the time with us.
Can I get 2 plugs in? Can I do 2 quick plugs?
Please, go for it.
So one, yeah. I run a journal called Digital Biomarkers, currently free to submit, open access. So if you and your colleagues are writing papers in digital health, we're delighted to have them. We have an editorial board that includes people from the pharmaceutical industry, from tech, from the FDA, from NIH, and from academia. And then second, if people are interested in Parkinson's disease or neurological disorders, we run our Center for Health and Technology that's delighted to help people investigate these things. We've done some work with Pfizer. We're doing work with Biogen and the Apple Watch. We've investigated a wide range of sensors. So if people have studies that they want to be done, we're even doing one study now where we're looking at an Emerald device, an MC10 wearable sensor, a smartphone, and a video analytics tool, and a 50 study of so-called super users of all these tech doing assessments in the clinic and at home for over 2 years. So if people are interested in learning more about those or working to investigate these things for neurological disorders, feel free to drop me an email. And then after you have the voice recording up for some time, you can take it down, destroy it, so I'm not quoted for the next long times. I try to be blunt and ask me anything, but sometimes I get myself into trouble.
Not at all. This was fantastic, and yes, we will protect your honest discussions. This is terrific for our members, Ray, and we really appreciate you. All right, everyone, thank you so much. This was a great discussion. Have a great afternoon. I'll talk to everyone soon.